Think of the heart here as kind of a shortened boot with the toe pointing out to the left side. Okay, so we have an anterior view here. We're looking into a patient's chest, and we're going to see sort of counterclockwise here going around the edge. We're going to see the right atrium along the right side, the right ventricle along the bottom, the left ventricle along the left side, the very tip of the heart, the toe of the boot, if you will, sticking out, we call the apex. And up top, we might catch a little bit of the left atrium there. I've abbreviated left atrium, LA there. That's just because I had to squeeze it into a tiny space. Don't walk around in a clinical situation talking about LA, RA, LV, RV. No, I don't think anyone's going to know what you're talking about. And of course, I forgot to add, the heart is resting on the diaphragm or enveloped in the pericardial sac, which is resting on the diaphragm. We have great vessels, very large vessels attached to the heart, and we need to know about those. So draining into the right atrium, we have the vena cava. Vena cava means hollow vein. So there's a big one up top called the superior vena cava. There's a big one down the bottom called the inferior vena cava. These abbreviations, these are legit. You can say SVC, you can say IVC. Everybody knows what you mean, and you get full credit on a quiz in anatomy for just SVC or IVC. If you're ever in doubt about whether or not you can use an abbreviation as a legitimate way of describing something or naming something, just check the bold terms. And if the abbreviation is there in bold in the bold terms, it's good to go. If you look at the top of the heart, reading from left to right, looking from the patient's right to the patient's left in this direction, there are three major great vessels up top, and they are in this order. The SVC is the first one on the right, the patient's right. The aorta pops out next on the left, and it has a wild, curving, candy cane-like shape to it. And then the third great vessel poking out the top of the heart is the pulmonary trunk. PUTK is not a legitimate abbreviation for pulmonary trunk. I just didn't have a lot of space to squeeze that in, so that's just me. There is a pericardial sac enveloping the heart, wrapped around, cloaking the heart. We distinguish between two parts of it. The part that's in direct contact with the heart is the visceral pericardium in green here. It's intimately attached to the surface of the heart. And then reflecting from that, facing away from the heart, the other part of the balloon, if you will, wrapped around the heart, is the parietal pericardium. That's in red. All the way on the outside is a tough, leathery layer called the fibrous pericardium. It is intimately attached to the parietal pericardium in red there. And this blue fibrous pericardium is non-compliant, meaning that it has a maximum volume. At that volume, you can really increase the pressure as much as you want, and it's just not going to get any bigger. It's super tough, super tough. And there's sort of an upper limit on its volume. It's not going to just expand indefinitely like a lung would. The fibrous pericardium is very leathery, very tough. In between the visceral and parietal layers of the pericardium is what is normally a small volume of space filled with pericardial fluid. And there might be something like 20 to 50 milliliters of fluid normally in the pericardial cavity. There is the possibility, though, of an abnormal accumulation of fluid in that pericardial cavity. This could happen, for example, with pericarditis, which is inflammation of the pericardium. The inflammation could occur, say, due to an infection, and it would lead to symptoms like chest pain. The inflammation would cause rubbing, which would hurt. You might hear this sort of abnormal rubbing sounds if you listen with a stethoscope. You would see changes in the electrocardiogram from that patient, and it might produce a pericardial effusion, which is an accumulation of excess fluid in the pericardial cavity. So instead of the normal, 25 or 30 mils, you might have 100 or something like that. You can treat pericarditis with anti-inflammatories. If a whole lot of fluid accumulates, it can actually compromise heart function. You can end up in a situation that's called cardiac tamponade. And cardiac tamponade works like this. You have a severe effusion. The more volume occupied by excess fluid in the pericardial cavity, the less volume there is here to fill the ventricles with blood. The reason for that is this tough outer layer, the fibrous pericardium, that puts an upper limit on the total volume inside this whole space. If you're putting a lot of volume into this pericardial cavity, that just subtracts from the volume that you can use to fill the ventricles. So if there's a severe effusion that decreases the volume available to fill the ventricles with blood, that's going to decrease cardiac output. So less volume of blood in the ventricles. When they contract and squeeze the blood out, you get less volume ejected. Okay? If you compromise cardiac output, that can lead to a situation called hypotension, which is just low blood pressure. And hypotension is going to endanger the ability of the heart and the cardiovascular system to perfuse, to supply blood to the brain and other organs. A region of tissue or an organ that's poorly perfused because of low pressure will encounter ischemia. Ischemia is a term we use to refer to low oxygenation, poor delivery of nutrients to that tissue or organ. And then if the ischemia is severe and long lasting, you end up with necrosis, which is the death of cells and tissue. For much of the body, that's an irreversible outcome. To summarize, we have the heart enveloped by the pericardial cavity. There's normally a small volume of pericardial fluid. If excess fluid accumulates here, say because of pericarditis, that's one possibility, that's bad. If a whole lot of excess fluid accumulates, you end up with cardiac tamponade, and that can be life-threatening. The treatment for cardiac tamponade is to use a huge needle. The emergency acute treatment is to withdraw fluid directly from the pericardial cavity using a needle inserted through the anterior chest wall. They usually go just left of the sternum and try to sneak it just inside of that cardiac notch in the left lung. That cardiac notch is useful. It gives you a little space to access the pericardium without hitting the lung.